Hello everyone, my name is Victoria Saint. I am originally from Adelaide, but I live now in Germany and work at Bielefeld University in the School of Public Health. And I'm coming to you here, I'm recording from Berlin, late actually on a Saturday night. And I will be talking today as a guest lecturer for Module 9 on Global Health Policy and Advocacy Landscape. And I thought I would start by maybe just introducing myself a little bit. So I grew up in Adelaide and studied at Adelaide University. I did a double bachelor health science, social science, majoring in psychology and public health. And I then went to Uppsala University in Sweden. It's a little bit north of Stockholm. And I did a Masters of International Health there, where I specialized on health equity and social determinants of health issues, particularly related to maternal child health. I then spent about 8 years working in global health, in particular working with the World Health Organization and other United Nations agencies and partnerships related to health. And again, with a special focus or focus on equity and social determinants of health issues, looking in particular at how to integrate equity and social determinants into health policies and health services and health programs within WHO and in national governments, and also looking at how to strengthen intersectoral action, multi-sectoral action, health in all policies. So the way in which the health sector can be working with other sectors in society and in government in order to pursue health and wellbeing goals. I moved to Germany. My husband is German. I moved to Germany 6 years ago. And 2.5 years ago, I left the United Nations system and started working at Bielefeld University. I'm doing my PhD, and I'm also a lecturer and a researcher, and we do a range of research on equity, global health, structural determinants, social epidemiology. So we have a diverse portfolio of research. I'm going to screen share with you now. Let's hope this works. So, as I mentioned, I'm going to be talking about the global health policy and advocacy landscape and trying to, in about 45 minutes, give you an overview of some of the key priorities, policies and players in the changing global health landscape. And so, the objective is just to give you a broad understanding of this space. I'm going to start with a quick definition of global health and then give you a bit of a historical overview of some of the important geopolitical and ideological and economic transitions that we've had and that form the backdrop of global health over the last 20 or 30 years. I'm going to do a particular focus, bit of an overview of the World Health Organization. Then I'm going to look at some of the changes and challenges in the global health landscape, in particular in terms of stakeholders. And I'll give you one example, which is you've got a case study reading on this or a publication, but to give you a bit of insight into how the national and global strategic priorities and developments weave together in different ways. So starting with an introduction of global health, you can see here this slide shows the number of journal articles from PubMed, from the PubMed database that reference different branches of health. And you can see public health, the big yellow one, as obviously the dominant overarching discipline, so to say. But this purple one here is global health, really kind of increasing in particular in the last 15 or so years. And also I wanted to highlight here these green and blue ones. So these new, even newer than global health, these new emerging fields of One Health and planetary health. So One Health being the idea of the fact that the health of humans, the health of the environment and the health of animals, both agricultural and domestic as well as wild animals, are tightly interwoven and you need to pursue the goals in a unified way. And planetary health, which absorbs that idea, but also kind of emphasizes the need to live within our planetary boundaries. If you're interested in the kind of development and evolving disciplines, then I really recommend this source at the bottom. And throughout many of my slides, you'll see that there's a source at the bottom. This is a great little overview. And this Global Health Now is a daily newsletter of all global health news that's interesting. It's published by the Johns Hopkins School. It's fantastic if you're interested in global health topics. So the most common definition of global health is Copland and colleagues. And that is the area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. This emphasizes transnational health issues, determinants, and solutions. It's multidisciplinary, and it also emphasizes a synthesis of population-based prevention and health service efforts with individual-level clinical care. I also like this definition by Biegehol and Bonita. It's a bit shorter: collaborative transnational research and action for promoting health. And while it's shorter, it's full, and I've taken the liberty of unpacking some of these issues for you. So, you know, really emphasizing again the complexity and multiplicity of structural and social determinants and the complex array of institutions involved within the health sector and outside the health sector. This idea of transcending national boundaries and transnational institutions, the need to generate a strong evidence base, but then the need to use this evidence base to inform good policy and good practice. The multisectoralism, which I'll focus on a bit later, is really here. So looking at the needs of strengthening primary healthcare and health systems, but through a multisectoral and a whole of government approach. And then the importance of kind of aiming for and pursuing the full range of public health and health promotion strategies, from prevention right through to palliative care, and really emphasizing action that tries to address the underlying social, economic, and environmental determinants of health. And this one shows the kind of, another way of representing those bubbles that I showed in a few slides earlier. You can see global health here coming out. But what I think is very interesting from these authors, Haverman and Bösner, is this bottom part, the grey box, where they really emphasize how, you know, the early public health and international health aspects came about in our colonial period. You've got then the Cold War, or end of World War II, and the Cold War period, which is when international health was dominant, but emerging was the global health field. And then you've got, you know, this era of globalization and kind of free trade, and global health has really come about in that space. And I want to unpack this issue a little bit. And I'll start by looking at the kind of recent history. So first, looking at these two people, we've got Margaret Thatcher, who was Prime Minister of the United Kingdom, 1979 to 1990, and then Ronald Reagan on the right, who was obviously President of the United States in the 80s. And these two really heralded in this age of what I would refer to as neoliberalism, or a free economic liberalism. And that really underpins recent history of global health. So I'm going to be focusing on that. This one, the pink image, is from Mexico, and this is protests against the imperialism of America in terms of neoliberal ideology and the interventions of America in Mexico in terms of public health services and other public services. So looking at kind of in the 1950s and 60s, there was a real focus in the public health and global health space on disease eradication, in particular for infectious diseases. On the left, you can see here a poster from India on eradicating malaria through spraying. And on the right, obviously, we've got the celebration of the end of smallpox through the smallpox vaccination. And these programs really represent what we call vertical health programs. So they focus on one disease. They're very specialized. There's not a lot of connection with other disease programs, nor with the wider living or health conditions of the population they're serving. They're quite focused, and we call that vertical health programs. But there was increasing recognition in the 60s and 70s that This was perhaps effective when you have a great technical solution. For example, smallpox, when you've got a vaccine, the vaccine is easily kind of dispersible and deployable. The programs run smoothly, but most of the other vertical programs were really having problems because they weren't addressing these underlying determinants of health, and because they weren't connecting. The health services and the different health programs were not connecting to each other. So they were inefficient. And sometimes also, ineffective. And in that context, the idea of primary healthcare really emerged, and the international conference that was held on primary healthcare in Kazakhstan in 1978, when it was part of the USSR, was a really a milestone in global health and international public health. So the countries of the World Health Organization and the United Nations participated, and they had a vision of pursuing health that was comprehensive, that looked at the full range of requirements of a population, health and well-being perspective, and that was universal. So this idea that every citizen has a right to access health, and that a goal of the national governments and a goal of the international community was to ensure that everyone could reach their full health potential. And this really pursued a horizontal approach, a much broader understanding of how health and well-being needed to be achieved in society. So out of this conference came the declaration of Alma Ata on primary healthcare. I'm sure many of you know of this, so I don't want to spend too much time on this, but it was really a groundbreaking milestone in international health, and it called for urgent and effective national and international action to develop and implement primary healthcare as a means of achieving health equity, health for all. It reaffirmed health as a fundamental human right. It reaffirmed that people have a democratic and participatory right to be involved in the planning and implementation of healthcare and health policies. And it understood primary healthcare as a set of essential health services based on practical, scientifically sound, socially acceptable methods and technologies that everyone should be given a right to. So while there were some really important aspects of global health, there were also some challenges. So primary healthcare was criticised for being unrealistic and idealistic, that it was too broad in scope and too vague without strategies or targets or objectives or timelines or financing, and that this made it not feasible. This made it a kind of an unrealistic and unfeasible agenda or paradigm for national governments and the international community to pursue. And as a result of that, there was some really unequal development. So some countries really picked it up and ran with it, but in many countries, the primary healthcare vision floundered. And part of that was a lack of investment of finances, both within countries and in the global level, to commit to finances for pursuing primary healthcare. And that reflected also a lack of political will to also tackle some of the underlying equity and social determinants of health issues, to a lack of political will to really provide people with their democratic and participatory rights in dictating health services or designing health services and so forth. So there were some challenges. And at the back of this context of primary healthcare was really two other really important things that happened. One was when the declaration was declared, the financing was never really clarified. Who should finance it? So within a country, within a national government, who should finance it? It obviously requires more than just financing from the Ministry of Health, but also at a global level, who should really support low and middle income countries in particular to pursue primary healthcare and achieve primary healthcare in their countries. And at the same time, in the 1980s, we had the sovereign debt crisis. So many countries went into significant financial challenges. And as a result of that, we had this, or kind of in alignment with that, and also as a result of that, we had this idea emerging of selective primary healthcare. And the example here that I'm showing is Child and Health Survival from UNICEF, the Child Health Organization or program of the United Nations, who created this GOBI program. And GOBI is the growth monitoring, oral rehydration therapy, breastfeeding and immunization. So that was essentially the idea, like, yes, we agree with primary healthcare, we agree with the vision of it, but we need to pick particular aspects that we're going to focus in on, child health and survival, and we're going to pick particular services that we're going to focus on and priorities that we're going to focus on. And in this case, it was these 4 that I'm showing, the 4 GOBI ones encapsulated in GOBI. And so this really represented a shift away from comprehensive to selective primary healthcare. And coming back then to kind of Margaret Thatcher and Ronald Reagan, I mentioned neoliberalism and free economic liberalism, and that really has shaped and formed the backdrop of global health, and it really has dictated how and what gets funded and how it gets decided and whose priorities are heard and so forth. It's had incredibly powerful influences. And neoliberalism, really has these key things that I'm showing on this slide. So it promotes the idea of privatization, that services should not be provided directly by government, the government should be smaller, and that services should be provided through the market, that the market is more effective and more efficient. Fiscal austerity, that governments should be relatively small, that their budgets and tax should be relatively small, and that they should always stay in the black and not go into the red. So they shouldn't do big public investment projects that draw on loans and debt, but they should also they should always be kind of in the safe zone financially. The deregulation of markets and the promotion of free trade, both within countries and regions and at a global level. So this push for globalization, intense globalization and free market economy, that everyone should compete in the same global economy. And as I mentioned, kind of reductions in government spending, and all of these issues then create an incredibly strong enhanced role for the private sector in all aspects of the economy and all aspects of society. So the provision of health services, the provision of social services, the building and maintenance of infrastructure like roads or housing or hospitals should all, that all of these things are best positioned and done in the private sector by the private sector. And what this represented more fundamentally, more ideologically, was a shift away from health as a human right to health as a commodity. So we stopped being citizens with rights or humans with rights, and we started being consumers pursuing this commodity of health that we purchase in the market. You could really see this in the World Bank, the world's multilateral bank. In the 1980s, the World Development Report said that the eradication of disease has much broader social benefits, that costs should not be the only basis for policy choices related to health, and that the use of prices and markets to allocate healthcare is not desirable because of the costs and the consequences and the inequalities of that. And only 13 years later, you can see this huge discourse shift, an ideological shift, where they say healthcare should be affordable and effective for the system, that there is a need to use cost-effective analysis, and that user fees and the use of the private sector to deliver health services should be promoted and encouraged and actively pursued. So it's a really big shift that this represents. Importantly to note, though, I mentioned the Declaration of Alma Ata in 1978, and in 2018 was the 40-year anniversary of that, and there was a big conference hosted by Kazakhstan on primary healthcare, that kind of where the country leaders recommitted to the vision of primary healthcare as essential to achieving universal health coverage. And that it recognised that some of these really important values and principles of primary healthcare had been lost in the intervening years, or undermined in the intervening years. From a policy perspective, I just added this slide in just to show the way that a kind of a global declaration in the UN system gets developed. So this is just one example, but it quite often involves the similar types of activities, where there's an expert meeting to develop a kind of first draft or first vision. There's an online public consultation. There's a international advisory group that then considers what of that to take on board, and who really hones the policy or the declaration. The government of Kazakhstan, WHO, and UNICEF as the kind of three organising bodies of this big primary healthcare conference in Astana, then have the space to kind of shape up their agenda. It goes out for a second round of online consultation, and there's the opportunity of MS member states, so the countries, to also provide significant comments. So this is public consultation globally, and this is an invite-only consultation process. And then there's an in-person member state consultation program, usually represented, for example, by the health attaché or someone from the embassy in a country. Like WHO is headquartered in Geneva in Switzerland, and all the WHO, there's always a health attaché or focal point for the countries. And just lastly, that this process, this declaration also informed a United Nations General Assembly, a high-level meeting on universal health coverage in 2019. This was one of the only times historically where the whole UN General Assembly had a meeting exclusively focused on a health topic. It's only happened a few times in history. One was on HIV/AIDS, and this one was on universal health coverage. As public health students, I hope many of you know what the Ottawa Charter is, so I don't want to spend too much time on this, but the Ottawa Charter was also an important historical milestone in the global health discourse and global health space. That was held in Canada in 1986, and that was an agenda for achieving health for all, so this equity principle. And I think an important area is that it really recognised these prerequisites for health, a recommitment to not only health as a human right, and the pursuit of health as a societal goal, but also the fact that to get good health and well-being and ensure that for your population, there are a set of prerequisites that sit outside the health sector: peace, shelter, food, and even a stable ecosystem. So these issues were recognised, this multi-sectorality and intersectorality was recognised. Skip that one. So I graduated from my master's in end of 2009, start of 2010, I got my certificate. And in that period, we were focusing on the Millennium Development Goals. That was the overarching global agenda, development agenda. So this was agreed in the Millennium Summit in 2000. And all of the United Nations member states, plus many of the international and multilateral organizations within the UN system and other important UN partners, committed to achieve these 8 Millennium Development Goals by 2015, eradicating extreme poverty and hunger, primary education, gender equality, improving child health and maternal health, HIV/AIDS and malaria, environmental sustainability, and this cross-cutting goal of global partnerships. So these were ambitious goals, and these agendas, are always meant to kind of promote coordination and high-level political will and visibility and mobilize finances. And this was a 15-year development agenda for the world. And the focus was really on low and middle income countries. So the kind of backdrop of this was really that high income countries and the international community should support and finance low and middle income countries to improve the conditions of these types of issues. But there wasn't a lot of reflection on the fact that, poverty and education and mortality or gender inequality are happening in the high income countries as well, which is an important segue, because then in 2015 to 2013, we're under this new paradigm, the Sustainable Development Agenda, or the SDGs, the Sustainable Development Goals. And this really recognised that all countries have development agendas, and that no country is without poverty or without people who are suffering hunger, etc. And these are global goals then, or global in the sense that all countries need to be pursuing these goals. There are 17 of them. You can see them in the graphic on the right. And underneath each goal, there are a set of specific targets and indicators to track those targets. And you can see these traditional goals from the Millennium Development Goal period here in the top row, but also this important, these additional goals, which really aim to connect the social and human development agenda with the environmental agenda and the climate change agenda and the Paris Agreement, for example. So, these focus on energy, water, land, climate action, etc., and the importance of the economy within that space. This is just another way to kind of represent those different dimensions. So the biosphere, the planetary aspects here, you've got the societal goals here, health here, I'll come to that in a second. And then the economy is an important component of society. And again, this cross-cutting goal, partnerships for the goals, which is 17. So let's look then at health in the SDGs, goal 3. So the overarching goal is ensure healthy lives and promote well-being for all at all ages. So you can see this broader understanding of health as including well-being and including promotion for all, this equity aspect, and at all ages, the recognition of the need for a life course perspective, not that you just target health for a certain condition at a certain point in time, like a woman when she's pregnant, or a child when they are born, or a boy when he becomes is in puberty phase. So you don't just look at people in this specific time frame or for a specific condition, but you have to understand that health and well-being is accumulated over a life course. It includes a range of priorities, so reproductive maternal child health, communicable diseases, non-communicable diseases, universal health coverage, as well as medicines, vaccines, and diagnostics. And it also calls for increased financing, increased investment in research and development, and strengthened capacity for risk reduction and management, including in terms of epidemics and pandemics. These are the goals. I don't want to go into too much detail because I know I've only got 45 minutes, but just to flag that universal health coverage then has become the overarching kind of umbrella indicator or target for the goal 3 overall. So you'll see a lot of health and development agencies will kind of position their work vis-a-vis or underneath a universal health coverage strategy. The Sustainable Development Goals are integrated and indivisible. So there's this recognition that achieving one goal depends on another goal and is a precursor also for another goal. This was an early mapping done in 2016 when the SDGs were first released from the team that I was working for at the time in WHO, showing health is up here in the right corner, the red, just showing the linkages as we tried to map out the different the evidence base of the different ways that goals and targets within goals were connected to each other. And as a whole, this one was later published by WHO as a whole, but really the argument here or the vision here is that health is determined by all the other goals. So the achievement of health depends on the achievement of other goals like no poverty or good working conditions, clean water, clean environment, etc. And in turn, that health is a precondition or a prerequisite for the achievement of other goals. So you can't, for example, have a productive economy if you don't have a healthy workforce. If people aren't healthy, then they're not going to be able to concentrate in education and school. If we don't have a focus on good health and well-being, then we're not going to achieve gender equality because girls and women are so vulnerable biologically and because of gender inequality. So it really tried to map the intersections here. And Dr. Tedros, the Director General, who is in his first term, just about this year will be the end of his first 5-year term, and he's coming up for re-election next year, currently uncontested, so it's likely he'll get his second term, says all roads lead to universal health coverage. This is our top priority at the World Health Organization. For me, the key question of UHC is an ethical one. It's a human right. So you can really see this emphasis on universal health coverage as this overarching umbrella agenda and emphasizing the social, economic and political determinants of health. Just in case you don't know what I'm talking about, universal health coverage. So it's the goal that all people can use the full range of health services they need, that the services are of sufficient quality and are evidence-based and effective, and that using these services does not expose the user to financial hardship. So it's about having financial protection through, for example, a health insurance system or a tax-based insurance system. Of course, as we track progress for the SDGs as a whole and the health-related SDGs, we're seeing unequal progress being made. And this is a very common pattern, but the low and middle income countries in Africa, particularly sub-Sahara Africa and Asia and Southeast Asia, struggling and are needing much more support from the international community to really achieve these different goals. I'm going to skip these two a little bit and go to this one. So I focused here on World Health Organization, just to give you a bit of insight into how this organization works, but I do want to emphasize, it's not one-to-one. Global health is a very broad and dynamic landscape, but just to have some slides here focusing a little bit on WHO. It was founded in 1948 in Geneva, which is when the Constitution came into force. And it was created in the post-war period, post-World War II period, under the auspices of the United Nations as the UN-mandated health agency. If you're interested in the history, there's a very lovely little photo series and history series here from the Regional Office of Europe. This is the Constitution being drafted, and this is here at the bottom right is at the Palais des Nations in Geneva, the United Nations Palace, being the Constitution being declared. And the primary role of WHO is to direct and coordinate international health within the UN system. And it works directly with countries to coordinate and support country level, regional level, and global level efforts. And its headquarters is in Geneva, in Switzerland. It's got 6 regional offices, and every regional office has a capital. Australia is in the Western Pacific regional office. The capital is in Manila. Or the headquarters, sorry, is in Manila. There's about 150 country offices or offices in countries and territories. So, for example, Kosovo also has an office. There's about 7,000 staff in the World Health Organization in total. More than 50% of them work in country level. Some of them are technical officers, but many of them are also medical officers, literally delivering vaccination programs or medical services like antenatal care, for example. WHO runs on a 6-year cycle. It has a big strategy every 6 years that it develops, the general program of work, it's called, and that's broken down into 3 bienniums. And so there's a cycle of programming and policy making and financing that happens every 2 years and 6 years. That's the big kind of the big waves in WHO. Where does it get its money from? So WHO is partly financed by the member states, by the 194 member states of the World Health Organization, who pay what we call assessed contributions. And these assessed contributions are called that because they are assessed based on the GDP, the income per capita of the country. So rich countries have a higher assessed contribution than low and middle income countries. But as you can see here, that's only making up less than a quarter by now, and 3/4 or more now of WHO's financing come from voluntary contributions. So these can be additional money paid by particular countries or by other organizations, so foundations, civil society, and so forth. And that's a big part, more than 75% of WHO's financing. And the last point is just that WHO really makes an effort not to take too much money from the private sector directly, and particularly doesn't take cash directly. So there are some in-kind donations, but it's usually less than 1%. So, for example, we're currently in the 2021 program budget, and the budget is $5.84 billion US. These are the distributions of where that money's going. So a big chunk going to universal health coverage, country support, and health emergencies. And then you've got some of these other programs here. And of course, WHO in the context of the COVID pandemic is mobilizing and calling for additional fundraising. And I think sometimes people think, oh, 5.84 billion, that sounds like a lot of money. So I wanted to just provide a few points of comparison. I live in Germany, as I mentioned. The health expenditure in Germany in 2019, just in Germany for its health system for 82 million people, was 410 billion. The US National Institutes of Health in the USA, 30 billion. Biomedical research worldwide is estimated to be 70 billion. And even 2 people, the Bill and Melinda Gates, through their foundation, have donated 45.5 billion to charitable causes in the last few decades. So it sounds like a lot, but when you think that WHO is responsible and accountable to every country in the world, every person in that country or in those countries, and for every single health issue, including that the portfolio of health is expanding, traditionally more focused on infectious diseases and maternal health, but now really expanding to a full portfolio of climate change and emergencies and health promotion and aging and LGBTIQ issues. So the portfolio of its responsibilities is enormous and always expanding in its budget. doesn't necessarily keep up with that. I don't want to spend too much time on this, but just to say that with the assessed contributions, WHO can decide through its member state process what it does with that money. But these voluntary contributions, the donor, the country or the organisation donating that money has the choice to either let WHO decide what we call unconditional funds, or to decide, so the donor says, we want you to spend the money on this health issue in this country in this time frame to do these activities. And that's the vast majority, 90% of the voluntary contributions. And the reason I highlight this is because it means that the decision-making around WHO for financing is being dictated by donors with money. And it means that WHO has very little flexibility to move money around when issues come up. So when the Ebola outbreak happened in West Africa, the epidemic in West Africa in 2015-16, WHO literally couldn't move any of its money to support that. And we're seeing a similar issue with the pandemic now. This is the 2021 budget. Germany is actually the highest donor for voluntary contributions, but also, for example, the Bill and Melinda Gates Foundation, the second biggest donor to WHO in terms of voluntary contributions. How WHO actually works then through this top-down and bottom-up approach. So there's a World Health Assembly held in May every year in Geneva, where the resolutions of the World Health Organization and the global health priorities and mandates and budgets are all set, and they're voted on by member states. WHO then has the responsibility to coordinate all of the implementation and action for all these activities and support countries to kind of take those things on board into their own national policies and programs. WHO is a normative agency, so it does a lot of work to develop guidelines and tools and resources and guidance documents, both at global and regional level. And it directly supports national health policy strategies and initiatives. So if a country is coming up to review a national strategy on non-communicable diseases or diabetes or whatever, it can approach WHO and say, we would like support, we'd like your input on this. In terms of countries then, on the lighter blue on the right-hand side, countries obviously report into the various global health mechanisms and systems, so national health reporting. That can be reporting in terms of data, like diseases and surveillance and so forth, but it can also be reporting in terms of updates on the implementation of different initiatives or action plans or strategies. The sharing of best practices, the development of kind of case studies and the sharing of lessons learned, that can happen at subnational or regional level as well as at global level. As I mentioned, member states provide financial and other support to WHO, and then every year they go to the World Health Assembly. There's a country delegation every year. And importantly, WHO is a one country, one vote system. So the United States has the same vote as Madagascar. And that's important because, for example, with the World Bank, that's a shareholder-based voting system. So the more money you donate into or give into the World Bank, the bigger your share of the vote. And the United States is a huge funder of the biggest funder of the World Bank, and so has an incredibly strong hold on the World Bank's activities. So looking then at some of the challenges of this broader kind of players and partnerships and the broader issues in the landscape, the landscape has been changing a lot in global health, and there's more and more players and actors in the space. And I really love this report or this product from Van Schaik and Van der Paar, two Dutch colleagues, looking at the governance and democratic legitimacy and structures and systems. And they picked global health as a case study. And they said, the global health landscape in general has become an intransparent patchwork of organizations and interests, where objectives of public health, development, economy, security, and foreign policy dominate to various degrees and sometimes clash. In the field of global health, the World Health Organization is under siege, and the rise of multiple new actors in the global health system poses critical questions about the role that various organizations should play, the rules by which they should play, and who gets to set those rules. So if you're interested in the power dynamics in more detail, I really recommend this one. It's a very interesting case study. And to give you an example of what that really means, I mean, I think the most recent example and most kind of publicly recognized example was, you know, President Trump when he was president of the United States in 2020, as the pandemic kind of unfolded, heavily criticized and really attacked the World Health Organization, mobilized a huge amount of critical support against WHO, and then withdrew the United States, or started the process to withdraw the United States from the World Health Organization, including all of its money. And that thankfully has been reversed when Biden came into power. And he's re-engaged and re-engaged funding as well of the United States in the WHO system. Hoffman and Cole did a very interesting mapping exercise, systematic or network mapping exercise, looking at who references who works with who publishes and collaborates with who. And they identified kind of 203 major global health actors. The methodology of this is very interesting. If anyone's a methodology nerd, I recommend this one to look at. And they identified a range of different kind of global health actors here that they categorized under these categories you can see here. And in terms of global and civil society organizations and NGOs, examples include Red Cross, Oxfam, Médecins Sans Frontières, the Doctors Without Borders, Save the Children, Red Crescent, obviously, as well. Public-private partnerships, particularly in this context of neoliberalism that I mentioned, the idea that the private sector can do things better. We have this model of public-private partnerships where public agencies collaborate with private agencies in partnerships. And good examples of that are the Global Alliance for Vaccines and Immunizations and the Global Fund for AIDS, Tuberculosis and Malaria. Professional associations, for example, the American Public Health Association or the World Medical Association. Obviously, the UN are in there. That includes WHO, but also partnerships that are hosted at WHO, so independent partnerships, but their secretariat sits at the World Health Organization. There's a range of those, like the Alliance for Health Policy and Systems Research or the Global Health Workforce Alliance, and then other UN agencies and programs that have a health mandate or health-related mandate, UNICEF, UNAIDS, UNDP, the development program, UNFPA, family planning, sexual reproductive health. A few national governments, just because they are such big donors and big players, made the list, in particular from the United States, USAID, the AIDS Organization, and the Centers for Disease Control, CDCs. Private industry is in there, academic institutions, a few of them, multilateral bank, obviously that's the World Bank, philanthropic, I mentioned before how much they fund, Bill and Melinda Gates Foundation. And this is what it looked like. They tried to map the kind of connections and partnerships to see who acted as hubs in this space. So where lots of different groups are kind of hubbing around, or who were kind of the network nodes of different types of organizations. And you can see the World Health Organization here, but Médecins Sans Frontières, Doctors Without Borders, obviously. And these were some of the kind of the ones that really sat at the center of these social networks. So WHO, the Global Fund, USAID, Médecins Sans Frontières, United Nations Children's Fund, UNICEF, for example. And important to note is that 98.5% of the headquarters of these types of agencies are located in high-income countries. So this is an issue that reflects the fact that we still have this very kind of post-colonial structure to global health, and that the vast majority of the power and decision-making is happening in high-income countries. And that's where, if you're interested in, I think these are two great art sources at the bottom, but where we have this disconnect between those definitions I gave you early on that talk about how transnational we are and equity and interdisciplinary and so forth. But there's a real disconnect with how we actually practice global health in reality. So while it strives to redress global inequities, global health continues to be a construct that is promoted, studied, and dictated mostly by Northern institutions and scholars. And a dangerous myth has been cloaked around the young body of global health. It's a myth that hides uncomfortable truths about inequalities of power. So we still have a long way to go in terms of decolonizing global health and making it more transparent, more fair, as a more open space where actors from the low and middle income countries have true power to shape the agenda and set the agenda. If you're interested in governance, just to highlight, I mean, I've focused here really on the World Health Organization and agencies that sit within the global health governance space. So that's a space where the agencies themselves have a focus on health. However, for example, at the moment, there's big discussions around this intellectual property waiver for the COVID vaccines. And those types of discussions are not decided in the World Health Organization. That discussion is decided in the World Trade Organization, which is not a United Nations agency. So, there are other agencies where their goal is not health at all, but it might be political or economic, or social or foreign policy. And these have incredibly important roles to play. And then you've got important national and regional institutions that feed in. I've focused a lot more on these two at the bottom here. So I'm going to take 5 more minutes of your time. I just realized that I've just hit the 45-minute mark, including my introduction. But just to give you one example of the kind of ways in which country policy and country activities feed into the global space, and the way that the global space fosters and supports the visibility and promotion of these lessons learned. So I'm giving you an example from the Partnership on Maternal, Newborn and Child Health, and this Success Factors country case series, which you have been given the reference for of the synthesis paper. And just to say thanks in advance, to say thanks to PMNCH for these slides. I don't represent PMNCH. I was acting as a consultant for them when I was involved in this work. So the Partnership on Maternal, Newborn and Child Health, PMNCH, it's an alliance of more than 1,000 organisations in 77 countries, and their focus is on sexual, reproductive, maternal, newborn, child and adolescent health. And they provide a kind of a platform for trying to strengthen the visibility and the coordination and the mobilisation of finances and political will around objectives related to maternal, newborn, child and adolescent health. They're currently running under a series of 4 targets: reducing maternal mortality, newborn mortality, under 5 mortality, and achieving universal access to sexual reproductive health and demand for family planning. And I've just highlighted here where these goals sit. So SDG 3.1, 3.2. So I mentioned before the goals. An interesting 5.6 here. That's the gender equality goal. So, the right of sexual reproductive health and reproductive rights is also a gender equality goal, as well as being an SDG 3, a health goal. So there was this big partners forum that happened that this case study series got developed for. It took place in India at the end of 2018, India hosted. But that built on a series of partners forums, 2007, 2010, 14, and then this one in India in 2018. And that's quite common in the international global health community, that you see every 2, 4, 5 years, you see these big thematic events happening that aim to kind of mobilize the stakeholders within a specific strategic area of global health. They reflect on what's happened in the past, what they've learned, what's been done. They look forward to what needs still to happen and try and mobilize the agenda around that. So this was the kind of curtain raiser event that took place in 2018, and you can see Prime Minister Modi here. This is Michelle Bachelet, who was head at the time of the Partners Forum, but she also used to be the president of Chile. And you can also, we always need a celebrity, so Priyanka Chopra was there as well. This is just a bit more information about what the Partners Forum was trying to do, but this best practices one was where we were focused and where the case study that you read was focused. And the case study series formed the backbone of the forum. So basically it built on, in 2014, they had a Success Factors case study series, which demonstrated that about 50% of the progress that had been made in reducing maternal and child mortality during the MDG, the Millennium Development Goal period, was due to actually not investments in health sector, but investments in other sectors like education, water, sanitation, hygiene, gender and labour. So this really emphasised the importance of multi-sectoral action. and the PMNCH wanted to unpack that more and raise the visibility of multi-sectoral collaboration and health in all policies as an approach. So they put a call out for countries and organisations to submit great case study examples. There were about 360 proposals submitted, I think, and they picked 12 case studies. And the case studies were meant to be looking at these types of questions. So how are countries really collaborating across sectors? How are they making that work? What are the impacts of that for health and well-being? What are the challenges of that? What's not working? What are the obstacles? And what are the solutions and best practices to overcome these obstacles? And they looked at identifying 12 case studies across 6 priority areas for women, children, adolescent health: early childhood development, adolescent health, quality, equity, dignity, sexual reproductive health and rights, empowerment of women and girls, and operations in humanitarian, conflict and fragile settings. These are the success factor case studies that were picked. I don't want to go into too much detail, but just to highlight a few things. So I was the consultant that was supporting Germany case study, the development of the German case study and the Malaysian case study. Both of them were government-run case studies, but there were some other case studies, for example, from non-government organizations like the American Heart Association, from academic institutions, the Santiago University and Aga Khan University, and also, for example, from bilateral development. GIZ is the aid agency of the German government, and they were operating in Cambodia. And you can see there's a mix of different issues chosen: phone hotlines, better data, immunization, nutrition, childhood obesity issues. So a really broad range of issues, and also broad range of countries. You've got high income countries, middle and low income countries. You've got big and small. You've got coastal and landlocked. You've got a very diverse range of health challenges and health contexts here. And that was deliberate. That selection process deliberately wanted that diversity. And the outputs in terms of these case studies, we had this BMJ special series. You got that synthesis paper as your reading. There are also 12 individual case studies that focused on the individual country case study process. There were several commentaries by high-level political champions. There was a whole package of press and media and multimedia, social media materials, and there was a big social media movement around this, also engaging young people and women and so forth, communities. And then in the forum that I mentioned that took place in India at the end of 2018, the country teams themselves flew over and got to present their case studies to about 2,000 people, to the audience. The process to develop the country case studies was basically, once the countries were selected, we went into an intense period of country coordination, setting up agendas and plans and teams, looking at having a core team, but also identifying all the different stakeholders that we needed to be engaging with. We used a set of guiding questions, basically a methods book, to create a mapping of quantitative and qualitative and other data, to create a kind of big working report of the situation of the case study. We held a multi-stakeholder review meeting to capture the diverse perspectives of different stakeholder groups, government and non-government and community, who were involved in the different initiatives. And then there was the journal article finally was produced. And this process happened in every single individual country, and then was globally coordinated. The countries were, we as the consultants with PMNCH were coordinating the country efforts. If you're interested in the methodological reflections and the methodological process, I've put the reference here. We provided a kind of a reflective piece about that, and thinking in particular about what that really meant for COVID. But we were looking at answering these types of questions. Why is a multi-sectoral collaboration approach needed? What drove it? Who were the actors involved? What was the policy context? What was being considered? Why is the problem relevant for different sectors? So it's obvious for health why they would be engaging in a health topic, but why are other sectors engaging in the health topic? How do you build interest and investment and incentives and benefits for other sectors? How do you design a multi-sectoral collaboration to address a specific health problem? How do you mobilize resources? How do you set up these policies, programs and systems? How do you implement it? What's the process? How do you evaluate and learn? How do you overcome challenges? How do you operationalize? How do you scale up? what are the relationships and how do you create them and then strengthen them and maintain them across a very diverse range of stakeholder groups, sometimes with conflicts or tensions in their needs or their understanding, using different language. And how do you know if you're making a difference? So what are the markers of success and failure? What are the results that you're looking for? How do you attribute impact? How do you scale up? How do you learn lessons? And what's the reflective process? So finally, I know I'm a couple of minutes over now. This was just a few photos from the multi-stakeholder dialogue that we had in Kuala Lumpur. Some staff members from the national team, from one of the Malaysian universities who was supporting the process. This is the country office representative of the World Health Organization here. And importantly, we also had, as part of this meeting, we also had a sub-meeting that brought in really local level health workers who were involved in these. In Malaysia, it was a vaccine rollout for HPV, for human papillomavirus, cervical cancer prevention. And this local level engagement was incredibly important for us to really see how in different parts of Malaysia it really worked. So, final key messages then. Global health is an area for study, research and practice that places a priority on improving health and achieving health equity for all people worldwide. It's got a particularly strong emphasis on supranational, superterritorial and transnational health issues, determinants and solutions. It promotes interdisciplinarity and a synthesis of population-based prevention and promotion activities with individual level clinical care. And also the generation of robust evidence from a range of different disciplines and types of research, but importantly, the translation of that evidence and knowledge to inform good policymaking and practice. Global health is never neutral or objective. The global health landscape is incredibly complex, very dynamic, contested, and rapidly evolving. It's a highly political space. It is occupied by many, many different stakeholders and actors, both health and non-health actors, from local level to national level, regional level, and global level. And they all bring with them their different values and principles and priorities and perspectives and their vested interests. Global health it's a discourse, it's a space, and it's shaped by the language and politics and power and money and history and culture. It's very embedded in our current ideological and geopolitical space, and the issues at a geopolitical level play out within global health, and global health plays out within geopolitics. And so it's really critical to it's really important to have a critical lens when you're looking at global health issues, and to think about, for example, whose voices are heard, whose problems are prioritised, how are they framed and presented, which solutions are therefore pursued, whose interests are really served by this, why, how. So it's important to have a critical frame. Thank you for your attention and listening. I know I went a little bit over time, so I hope it was worthwhile. Yeah, best wishes for your studies, and thank you very much for your attention.